This excellent medical student-led podcast is for educational purposes only and not intended to be used as medical advice under any circumstance.
All right. Hi, everyone. Welcome back. We're episode 15, which is crazy. I'm here with Nick. We're doing our first episode together, which is super exciting. Nick was one of my first friends in medical school. One of my earliest memories of him is our first year. He would just walk to school with like a big bag of fried chicken that he brought at the grocery store. And I was like, Nick, I'm getting a little worried. I've seen you eating only fried chicken for weeks now. It's like, Nick, have you had any vegetables lately? And he just looks at me. He's like, is pesto a vegetable? So my roommate and I had him over for dinner and gave him broccoli. And here he is.
Introduced me to vegetables. Yeah.
All right.
Thank you. Thank you for that great introduction.
Of course.
I was worried you were bringing up the fried chicken. You seem to always do that. But yeah, so super excited. Thanks, Kevin and Dr. Abrams, for having us on and letting us kind of lead this discussion together. So for those of you that don't know me, I'm Nick and went to college in Seattle, and now super excited here as a third-year medical student, thinking about ER, but also like I am. And so head's kind of spinning, deciding, but we'll get there. And then, yeah, we have two really awesome guests that are classmates of Megan and mine. I'm really excited to have them on. So you guys can go ahead and just introduce yourself. Emma, you can go ahead first.
Yeah, so my name is Emma St. John. I'm also a current M3 here at Rush. I am originally from Bloomington, Indiana, went to Indiana University, and I've loved my time here in Chicago. Currently thinking I am, not totally sure. Unfortunately, I end with that clerkship, so I've not been able to do it yet. So time will tell a little bit. And I'm here with the other guest, who is one of my first friends in med school, and also my roommate, my current roommate, Veena.
Yes, my name is Veena. I'm also a third-year medical student. I'm from New Jersey. I went to college in Boston, and now I'm here in Chicago. I'm also thinking about doing internal medicine, also ending on internal medicine, so we'll see.
Awesome. Well, we're so happy to have you guys on the show. And I think without any further ado, we'll get started.
Let's say you guys are interns and you're on call in the hospital, and you get a page from the ED, and it just says 36-year-old male, altered, sodium of 113. Really, there's only one sentence here, but I really like this aliquot just because there's so much, like your head just starts spinning. There's so many different possibilities that could be here. So we'll start off with just generally, like, what are you guys thinking here? We have a young male with a sodium of 113 and he's altered.
He has hyponatremia of some etiology. Could be many etiologies. Something you could think about, because I'm on psych, you could think about substance use, so certain substances would cause it.
Yeah, so I think just taking kind of, because they're next to each other, like the altered and the sodium level, it's easy to start trying to draw how they're connected. But I think also remembering that those two things could be kind of separate etiologies. They don't necessarily have to be related. So thinking about causes for someone being altered, intoxication, and then you could just think kind of just systems-based stuff that would be independent of the sodium. So anything neuro-related, really, it could be so broad as to why someone would be coming in altered. He is a younger person, which is notable. Again, we don't really have like his medical history right now, so he may not be in great health, but that is also something that is kind of notable in that first sentence.
Yeah, definitely. So I think that, yeah, there's really not too much to work off of in this aliquot, but also a lot to work off. The sodium of 113 is not just kind of low. It's like you sometimes see people coming in like 128, 129. You're like, all right, not great, but I don't know. But 113 is definitely significant. So yeah, I like what you said about trying to decide, like, are these related? Are they not related? Because that's definitely kind of drives the way that you not only like think about the diagnosis, but also management. This is like a symptomatic versus like asymptomatic. So anything just right off the bat that you'd want to know, like history-wise? You guys are going down to see him. What is kind of your primary concern?
What's his level of alteration? Like, is he obtunded? Is he just like not oriented to like person, place, or whatever it is? And then, yeah, also just, what were the circumstances before he came here? Who brought him in?
Yeah, and then, I mean, I talked about past medical history, but that also including like what medications is he currently taking? Do we have any sort of like substance history at all with this individual? Those would be pretty important. Depending on how altered he is, you might have to get in touch with else to get that in. But that would be kind of like first line stuff beyond just kind of the immediate question of like, how altered is, how emergent is this situation?
Yeah, I think that's a really good point, because everyone says altered, but it's kind of what exactly does it mean? It can mean, I don't know, anything from just like not acting themselves to just being like completely out of it. So just definitely being able to like define exactly what altered means in this situation. I think we're ready to move on to the next aliquot. Okay, so a little bit more information for you. In terms of his past medical history, an unspecified psychiatric disorder. In terms of his meds, maybe he's been on some psych meds in the past, but doesn't seem to be taking any right now. For his vitals, he's 104/73 for his blood pressure, pulse is 63, temp 98, respiratory rate 19. I'm setting 99% on room air. Constitutional, not in any acute distress, not ill appearing, toxic appearing, or diaphoretic. HENT, neck, respiratory, cardiovascular, abdominal, MSK, skin, and neuro exam are all normal. And then in terms of the psych exam, he's erratic with disordered thinking, unable to provide a coherent history or past medical history, and speech is moderately pressured. So, some more information for you to work with. What does this new information kind of do with the framework that you were using to think about hyponatremia?
I mean, I think obviously the big standout here is this unspecified psychiatric disorder. It's a presentation that is looking a little like acute mania. And so I think that leads me more towards a medication or substance picture with the hyponatremia. I don't know what you're thinking.
Yeah, I mean, ecstasy zone.
He's not necessarily having symptoms of like, not necessarily everyone fits the picture, obviously, that the textbook picture that we're given, but like kind of warm temp, sweaty, dilated pupils. But he is having this pressured speech, manic type symptoms that you're talking about. Also, I mean, he's not been taking any medications. Certain psych meds do have a tendency to cause like SIADH, which could cause hyponatremia, like SSRIs or something like that.
I think if someone's also potentially in like having some acute psychiatric event, people can also just take in a lot of water or a lot of fluid, and that can, to the level that could cause like a hyponatremia, depending on kind of what their behavior has been like and what they've been going through while they're having this episode.
So maybe we'd get a water deprivation, or the thing for psychogenic polydipsia.
Yes.
I really like what you guys have done with only 2 like aliquots of information in kind of honing down like what would be the most likely causes here. Because like if someone would just tell me hyponatremia, I would think like things like heart failure and liver failure and kidney problems, which are all common causes of hyponatremia. But like you guys kind of looked at the age. You guys also looked at kind of the presentation here and the past medical history, and have already like named things like ecstasy or like drinking a lot of water. You even mentioned like SSRIs as a cause of it. So really kind of honing down just based on this information. I really like that.
I like how Nick started to put hyponatremia into different buckets, and traditional teaching is it's a volume thing. We're just terrible at judging people's volume status.
Yeah.
So we often now like focus more on labs, electrolytes to help guide our thinking. But I feel like this physical exam is pretty helpful in the sense that we can at least eliminate some of the big bucket causes of hyponatremia, being like the heart failure. There's no stigmata cirrhosis, the young guy. So that kind of directs you down one path. We'll see if it continues.
And I think that's a good point. I think also with psychiatric patients, it's really easy, especially if they're in an acute episode, to just kind of attribute all their symptoms to their psychiatric condition. And that isn't always, kind of what's going on. And obviously have a number of underlying health conditions outside of their psychiatric history. But I think for me, also the fact that, the whole physical exam seemed pretty was notable.
Yeah, definitely. And I think it's also important, like it sounds like when he came in, he was kind of altered, maybe not super cooperative with the exam. So I think always important to just kind of like take it with a grain of salt. Like, yeah, everything sounds like it's good for now, but I guess we really don't know. We got this exam after he'd like kind of calmed down a little bit. The vitals that he has is something that kind of stuck out to me, like with a pulse of 63 and a blood pressure of 104/73, like definitely sounds like someone that's pretty calm, not super agitated. So I guess maybe you can assume that he's, just a little more kind of calm down at this point. But yeah, always just like doing serial exams, I think, and maybe the first one isn't as reliable, but being able to go back.
Yeah, that's a good point. Like also when you're getting your vitals matters. So like, could this patient have been given a drug like Zyprexa or something that would kind of just calm them down? So like if someone's reading you vitals and you're not really there to see the patient, then like, if someone's hypotensive, like was this after a liter or before a liter bolus, those are all things that are, they're really important in terms of like how they're responding. So also something here is like, we can take these vitals for what they are, but then we don't know the context of it too.
And I like what Kevin said about just kind of I know the classic teaching is looking at like the volume status and is this like a hypervolemic or euvolemic, hypovolemic, hyponatremia. But yeah, the kind of the data and literature shows that we're not great at being able to like assess really the volume status of patients. And I was listening to a podcast earlier that had a nephrologist talking about a study that was done back in like 1987, where they basically just like lined up all these hyponatremic patients in front of these like really well-trained nephrologists. They're like, tell me what the volume status is. And only 40% of the time were they able to like accurately guess it. So, which is worse than flipping a coin. So I think there are a lot of like good physical exam findings that have been shown to have like really good like specificity for ruling in like an S3 is like great for if you're concerned about heart failure, but also like you can easily not have an S3 and you can not have peripheral edema and you can still be volume overloaded. So just all kind of important things that obviously the physical exam is very important. And this isn't to say don't do it, but just kind of taking everything, into consideration and not making a decision just solely based on that. So kind of going off of that, I know that we did learn like using volume status to assess it. Have you guys learned of any other ways to kind of like break down the different buckets of hyponatremia?
I think like you said, the classic teaching is like, or the only lecture I've had on it is like, euvolemic versus hypovolemic versus those are really the two that we kind of cover. But if we're going into like euvolemic and hyponatremia, that would be something more like maybe like psychogenic polydipsia in that sense, or which kind of fits more in the picture. But that we have right now based on his normal physical exam, and we don't know that it's like actually normal, like you've been saying.
Mm-hmm.
But yeah, if he was more like hypovolemic, we could be thinking of some hormonal imbalances that could be causing it. So maybe adding those on in labs like ADH, looking at the other electrolytes to see if he's like just depleted in general, to see if it's like a nutritional status thing.
Yeah, those are all really good thoughts. So kind of going along with that, I can't promise you will have all the labs that you want, but in a perfect world, what would you guys like to order now?
Yeah, so I think like what Veena was saying, definitely the rest of the electrolytes very important. Because they did give us the one, which leads you to believe that's maybe the only one that was abnormal, but yeah, that was like the most notable one. But so definitely want a full picture of that.
Like a CMP, creatinine level, maybe like BNP if it's like a heart failure type picture.
Maybe like a detox just for substances.
A UA for serum, osmolality. Or not serum.
Urine. We knew what you meant. Yeah.
Are you guys interested in a repeat sodium?
Sure.
Yeah.
Now that you mentioned it, sounds really reasonable. Yeah.
And I got to tell you guys, I had a case a little while back. Sodium was 106. The glucose was 2200. And it was all pseudo hyponatremia. And I'm saying that not because this is the case. Promise you, I'm giving you one hint right now.
Yeah.
But it was really cool to see that.
Yeah.
It's the highest glucose I'd ever seen.
Yeah, that's impressive.
2200, oh my gosh.
Did not know that was possible.
No.
I looked up the highest one recorded was like 2500. It's the highest one I think ever recorded. This guy was close.
Wow. That's impressive. It's not what you want to be known for, but
No, yeah, it is not.
all right,
Blood like maples.
Sweet.
Ooh. Well, I think that's a good start in terms of the labs. I think always just there's always just like this inclination, I feel like, to just order everything. But I think starting where you guys are and just getting like the really important stuff, like let's look at his electrolytes, let's look at the urine, I think are really good places to start, especially with something like hyponatremia and this guy that's like otherwise pretty healthy. Because a lot of time just with like a good history, physical exam, and like some basic labs, you can kind of get all the information that you need to know. So I think that's a good place to start.
And that's a good segue to our next aliquot of info. And you guys did a good job. You pretty much nailed most of the workup that was actually done. So we're going to kind of give this one to you in like two parts. So first, we'll give you the CBC and then some electrolytes as well. So the CBC was nothing abnormal there. And then the sodium we had is 113, chloride 82, the BUN was 4, creatinine at 0.71, calcium 8.6, and glucose was 108. So does this alter or change anything that you guys have thought of so far, or does it not really provide much?
Chloride is really low as well, so it could be like some like salt wasting, some kidney pathology, but the BUN and creatinine is not concerning.
And then like yeah, like the normal
Glucose. Yeah. Yeah. You're just talking about it. Right. I was ready for the case to have been 2200
salt.
Yeah. Yeah. The glucose is normal, which definitely is a normal finding that definitely says though.
Triglycerides were 75,000.
Right.
Just got IDIG.
But yeah, Veena, I think you
I
also
have seen it. Looks like a creamsicle coming out of your body. Triglycerides of like 5,000. It's
Hello. That'll get you.
but Veena, yeah, you had mentioned just the creatinine at 0.71 and BUN, like less concern for kidney problems. And I think that, yeah, that's definitely when you're thinking of hyponatremia and like organ system failure, we can't, from a normal creatinine, we can't just say there's nothing wrong with the kidneys.
Yeah.
But in terms of like acute kidney failure to where the kidneys are not producing any urine at all or something makes it less likely. But there's still like a lot of information, of course, that we need. And then,
Do we know their pH, if their chloride is really low?
So yeah, that's a good question. So in terms of like,
I can't calculate it.
So I think for discussion purposes, their bicarb was 24 and potassium was 4.
Yeah, I think that's all kind of good points. And just the first thing that you want to do when you see hyponatremia is make sure that it is true hyponatremia. And so we're kind of throwing around all the other things that can make it look like you have hyponatremia when you don't. Glucose being the big one, but also they kind of call that like the hyperosmolar hyponatremia, in which case you correct and you have that whole formula to correct for the glucose. And most of the time your sodium ends up being, and so sometimes people call that pseudo hyponatremia, but what I've kind of learned is that's not actually pseudo hyponatremia. It is truly hyponatremia, but it just corrects once you correct the glucose. But there is something else called pseudo hyponatremia, and that has to do with, and you have other things, other osmoles in the blood, like proteins and fats. And that just basically is a lab error. So it's the way that they like calculate the sodium when they're in the lab. It's way over my head, but basically they have to like dilute the sample enough. And then you have all these other like triglycerides and proteins and stuff in there. It can make the sodium look low when it's not actually low. So first thing you want to do is make sure that this is like a true hypoosmolar hyponatremia. Otherwise you end up going down the very wrong path. So yeah, if you are concerned that like maybe it's hypertriglyceridemia, you can get lipids. Concerned about like multiple myeloma or Waldenstrom's, you can get like an SPED. So yeah, all things to just consider once you see something like this.
So I got to ask you guys a question, because besides the sodium, there is a lab that really stands out there to me.
Oh,
and no, I actually have to say it's the BUN.
Oh yeah.
So the BUN is sort of unusual, would you not say so?
Yeah, I would say so. The creatinine was normal, so then I just kind of glazed over the BUN.
Yeah, I'd say sometimes I'm favor the creatinine when I'm thinking about a kidney too much. And, when I say BUN creatinine, just normal creatinine, and kind of fail to recognize that the BUN is also equally important to kidney function.
If there's anything about that BUN that seems strange to you guys? Pretty low, isn't it?
Right. We often don't think about what could cause a low BUN.
Yeah, I know if you don't eat a lot of protein. Yeah, for them. Right. I don't know what causes low BUN other than low protein. Yeah.
What's his LP? Also would be very nice to have.
Yeah, and I think it helps to think about like how, BUN rises in our blood and the mechanisms of that. Like, so when we're volume depleted, our kidneys like to pull the urea back into our blood. So like, when we have low volume status and there's something really high BUN, you may want to think like, oh, this patient could be dehydrated. The kidneys are working really hard to pull in urea. And like with ADH, a lot of people, we think about water, how ADH kind of brings in water, but also the hormone also pulls in urea. So it's just something to kind of think about when we think about it mechanistically. Low BUN can kind of tell us a little bit about volume status as well.
I think I was under the impression, you guys can correct me if I'm wrong, but also if there's some sort of like liver dysfunction going on, I think the way that proteins kind of metabolize, it's that it's turned into the urea in the liver. So if you have just like some underlying synthetic or metabolic dysfunction of the liver, that can also cause you to have low BUN. So we don't have any LFTs or anything here, so I think we can assume that they're normal and no stigmata of any sort of like cirrhosis or liver failure. But that's just was kind of in the back of my mind as something that can cause a low BUN. All right, so we got a UTOX, which is negative. We got the serum osmoles are 239, and reference range for that We like them to be somewhere between like 275, 295 is kind of what we consider the limits of normal. Urine osmol is 49, which is low, and then the urine sodium is less than 20. You guys want to break those down and kind of how that makes you rearrange your differential or what you're thinking? I know they're not labs that we get kind of frequently, a little more like advanced nephrology labs, but yeah, I mean, we can just start with like the serum osmolality, so a little bit lower than usual. So,
And the urine osmolality should be a lot higher than that.
Right.
And the urine sodium, I'm not sure the level should be. I only remember like the fractional excretion of sodium in terms of like kidney injury. I'm not sure that this quantifies, but as like a normal level of urine sodium excretion, should it be higher?
Would you want it to be higher?
I mean, probably not, right? Because theoretically, you should be absorbing like almost all of the sodium that goes to your kidneys. So there's something wrong with the kidneys in terms of reabsorbing water.
Right.
Yeah, excretion of lots of free water.
Yeah.
So ADH problem.
yeah, I think that's, I don't know, because all these can be kind of intimidating to look at, and you're like, oh, I don't remember the reference ranges, whatever, but I feel like if you just think about what you want the body to be doing right now, it's like your sodium to 13, you want it to be hanging on to every ounce of sodium that it sees. So you don't want to see a lot of sodium in the urine. You want the urine to be pretty dilute because you want to be getting rid of a lot of free water because this is a free water problem. So based on that, I think it's kind of what you would expect in someone whose kidneys are functioning normally. Because yeah, if you have kind of the other end of the spectrum is like an SIADH picture. And so I don't know if you guys want to talk a little bit about what you think you'd see if it were maybe something that like looked a little bit more like SIADH.
All of the water in the body.
Right.
But would this fit a picture of someone who has like the reverse, like diabetes insipidus? No.
Doctor, what would you expect? It's a good discussion point. What do you know pathophysiologically about DI?
There's two kinds. There's nephrogenic and it's central, not responsive to ADH, so then you'd be like not absorbing water, so your urine would be very dilute. You would be excreting free water.
Yeah.
Like this
Like a lot.
picture.
Potentially. What do you expect your sodium to do?
In your sodium would be extremely high because you don't have water to dilute the sodium in your body. Yeah.
But you're right. Looking at these,
urine, but since the urine looks the same,
Right.
Yeah.
But it's the sodium that would make it. Yeah.
Yeah, I think that just being able to like understand, you're like, okay, I know that this is what DI is, and then you don't have to memorize any of like the lab findings or anything that goes with it because you can just logically think through it and be like, all right, this is what we would expect with it. So yeah, I think those are all really good points. So yeah, just looking at kind of everything that we have so far, do you want to summarize just kind of where you think we are with the case and with the labs that we have?
Yeah. So I can kind of do the first. Yeah. So again, with the case, this young, seemingly otherwise healthy individual, some history of psychiatric disorder, who we don't think is taking any medications, but maybe have not confirmed, big question mark, who generally their exams seemed very normal, seem to be having some features of mania, maybe erratic. Sorry, when we got more complete labs, let's see, we talked about the BUN being low, but then the rest of that looked pretty good. Glucose wasn't elevated, the UTOX was negative. We talked about kind of the low urine osmolality and the urine sodium plus.
Well, I think that's good. And I think it's a really thing to stop and try and see one or two sentences, because now you can start reorganizing your thoughts. You guys have talked about so many great things, and now you're saying, okay, so here it is, this one sentence. So what are the things? And what do I know and what don't I? What do I still want to know?
Definitely. So I think now we know, okay, we have hyponatremia for sure, right? It's not with the glucose, it's not too much protein, it's not too much fat. And so now we have these urine studies with urine that's pretty dilute. So kind of going back to all the things that you were thinking about that can cause hyponatremia, which one of those kind of fits with the picture that we have right now? It could be a couple, it doesn't have to be just.
But Emma Brown, like a psychiatric patient, like drinking a lot of water, psychogenic polydipsia kind of fits this picture where they have a dilute serum and a dilute urine. And so I think the next step would be like, see if they don't drink water for a while and see what happens to their labs and redraw. I think it could still be another problem. Like, we shouldn't get too narrow and say, again, like, it's just a psych issue. We should make sure, because like you said earlier, Megan, like, less than flipping a coin might be that he's just like, we can't tell that he's falling, but it wouldn't probably cause this urine picture.
I think that's a really good point. And also with the urine, I don't know a ton about urine studies, and I don't know how much they can kind of like fluctuate, if it really changes a lot based on like at what point you get this urinalysis. Like, did the patient get it after he was like given fluids in the ED, or, you know, did he just recently like eat a bunch of French fries or not eat anything for the past 24 hours? And like, at what point you have to kind of worry about like collecting it over like a 24-hour period to really get a good picture of it, or if just like a one-time checking like the urine electrolytes and osmolality, if that can give you like a pretty good idea. So,
And I think especially with this patient who maybe is not able to give a great history or a great idea of the kind of the events leading up to their presentation, being extra careful and doing kind of repeat labs would be helpful, repeat checking.
And then also, I know you had mentioned, Emma, in the beginning, is like you didn't immediately attribute like the extreme hyponatremia to like the altered, because you said like, you know, you want to think about them differently. And I thought that was a good point. I think here with like the UTOX being negative, it's also just like adds more information that like maybe the sodium is like kind of the cause of the altered mental status. And then just before we forget, so for the UTOX, Megan and I were looking this up before, because Veena, you had mentioned ecstasy.
That's all.
Yeah.
I'm on psych right now.
Yeah. And like, so with ecstasy, patients lose their ability to regulate their kind of heat. And so they become really thirsty and they drink a lot of water. And that's kind of one of the mechanisms for why ecstasy can lead to hyponatremia. And in like an altered male with a psychiatric history, that's something you were thinking about. So we actually came to the conclusion that maybe ecstasy, there are some drug screens that don't screen for that. And so like we were thinking maybe it's in the amphetamine class, but we think it's actually maybe separate. We'll have to like look more into that. But also, yeah, for urine drug screen, like if the main drug that you mentioned isn't even on the screen, then that's something to think about too. But like I would say like, yeah, for these purposes, just saying that there's no, there's no like drugs on board that we know of gives us.
Right, great. So I know the big thing we're kind of thinking of is someone that's just taking in too much water. And like most of the time, hyponatremia is like a water problem. But there's also kind of like the little bucket of people that just aren't really taking in enough solute. Yeah. So I know you're on psych right now, Veena. If you've like seen any of this, or anything that kind of comes to mind with.
Oh, tea and toast. Yeah.
Yeah. But yeah, that and the beer potomania are kind of the two that they love to talk about. So yeah, the teaching is that it's like a water problem. And in that case, they are taking in like too much water, but also taking in like not enough solute. So kind of a combination of the two. Just another fun kind of trick that I learned while I was doing a little bit of research for the case is just like a fast and dirty way to check the urine osmoles is you can take the last 2 digits of the urine specific gravity and multiply it by 30. And that gives you like a pretty good approximation of what they are. So those are usually tests that you have to kind of send out separate. It's not going to give you like an exact number, but if you just want to estimate them, it's a little trick you can do.
That grab on this guy would be super.
Very long.
So next, aliquot information. So given the altered mental status, CT head was ordered. And this was notable for a hyperdense pituitary mass with supracellular extension concerning for a macroadenoma. Neurosurgery was consulted and recommended MRI self, which re-demonstrated the pituitary. So does this add, subtract, confuse anything in your mind? Also, would you guys have ordered a head CT? Like right off the bat, I wasn't even thinking of that at the beginning. But yeah.
I don't know that I would have ordered that just based on the information given, I guess. Yeah, I mean, I guess we don't have a really clear reason as to why he was altered other than this sodium and these labs that we've gotten. So maybe just because we don't have a great, like super complete picture at this point. But to me, there wasn't anything from kind of the history of the presentation that would make me want to order a CT, but also clearly they did. So they and they found something. So clearly it was a good call because they did obviously find something, but I probably would not have thought of that.
Have thought to order a CT head. Maybe I think talking through the different like electrolyte possibilities, maybe if it looked like more of an SIADH picture than I would have thought of it, because it can be like paraneoplastic or like something like in the brain itself.
Right.
But because we kind of, I guess we can't rule it out just based on these current like findings, but it doesn't seem to fit, then I wouldn't necessarily think there's something in the brain. We also kind of ruled out DI as well based on this, so I wouldn't necessarily think that either. I can't really think of any other brain reasons right now.
Yeah.
Maybe a stroke, I guess, can cause hyponatremia sometimes, but this is a mass.
So yeah, I think it's kind of like an interesting conundrum that they were in, because they have this hyponatremia and the patient's altered, and it's like, okay, well, they could easily be altered like from the hyponatremia, but also maybe they're dizzy from their hyponatremia, and maybe they fell because they're dizzy and stuff.
Right.
Yeah.
Right.
I think you could go either way. And I don't know. I mean, maybe if you like do a pretty good examination of their head and don't see any signs of trauma, you could talk yourself out of it. But they went for it, and so this is what they found.
Yeah, just before we like talk about the mass, just intracranially when you're thinking about hyponatremia. So the actual like number one cause of death in these patients is going to be like herniation of the brain. I mean, you know, there's some kind of cerebral edema that's happening. So maybe to like just get a sense like where's the brainstem in relation to the brain, where, you know, is there any midline shift or anything? But yeah, I think in terms of like looking for a specific cause, I think seems like the sodium was the cause of the altered mental status. But yeah, in terms of like this mass, what do you guys think about the mass? Megan and I, this kind of had us scratching our heads when we were reading through.
Let's take a step back.
Yeah.
Forget the case.
Yeah.
You're just given a patient with this. What do you think?
They have a brain mass. Yeah.
Some sort of like, pituitary adenoma, galactonoma.
And uncommon.
Is it common, or what is it common? I mean, it's the more common of those. Yeah.
But, I mean, thinking of the pituitary hormones, like growth hormone, LH, FSH, like ACTH, none of these. I mean, I guess ACTH can play around with electrolytes, but potassium is normal, which doesn't make me think of like an adrenal issue. And then obviously, like Emma said, prolactin, and then ADH. I mean, there's very rarely like a TSH issue when it comes to pituitary adenoma. I don't know. We can't tell if he has a TSH issue, I guess.
So yeah, basically what you guys are saying is that based on where the anatomy of this lesion is, you're thinking of all the hormones that are released from there. You're saying that there might not be an explanation for why the sodium is low based on those hormones. I think that's like really like good thinking there, you know, taking the anatomy, like the functional side of it.
Yeah, I think that's a really good way to think about it. And I think prolactinoma is like the first thing that comes to our head, because that is the most common of like the adrenal adenomas. In terms of the functional ones, or even have a non-functional one, just means that it's not secreting hormones, and most of the time can be kind of like impinging on nearby structures, and so can like decrease the secretions of some of the hormones. But I think you guys did a really good job of kind of going through all the different hormones and being like, okay, it could do this, but like it's not explaining what we're seeing. And so, yeah, I think that's just kind of like one of the best things that you can do in medicine, because a lot of times you do end up getting studies and you find things on there that you just weren't expecting to find. And now you're like, okay, well, now I have this information and I really don't know what to do with it, because it doesn't necessarily like explain what's going on, but also I need to make sure that I really take the time to like think through it and kind of piece everything together. So,
right. And I think it's also just all these different pieces of information, trying to, on one hand, see if we can connect them all, and on the other hand, give them all their own separate attention and work them up separately at the same time, which is sometimes a little difficult to do.
Yeah, it's tempting to sometimes try to fork
Information
based information you have,
right.
which is also one of the reasons why, you know, ordering a bunch of things is not always like the best call, because then you're stuck with the responsibility of explaining it, when sometimes there really is no relevant explanation and you're just going to make more work for yourself. That's good.
I think he's really unlucky though. He just has this random pituitary mass. And I mean, it's like it doesn't seem likely that it's like this same etiology, but dang, that sucks.
So yeah, my understanding is like in terms of pituitary adenomas, they are one of the more common, I think, lesions that you see in the brain. Most of the times are benign, so kind of found incidentally. A lot of times people go looking for other things and end up just seeing them. So But yeah, when you find something like this, you always have to consider that it could be malignant because there are some like pituitary carcinomas. And then just, yeah, thinking through all the different, like the pituitary does everything. And so just really thinking through all of the different kind of physiology of everything and making sure that there's nothing that you're missing.
I guess you guys probably would know this better than I do. The definition of macroadenoma is 0.5 centimeters. Is that, I somehow that number sticks in my brain, but I probably heard it 30 years ago.
I'm looking at said greater than 1 centimeter, but
Okay.
I'm sure I don't.
You may be right. The other thing is that, going back to diabetes insipidus with pituitary adenoma.
Mhm.
So it's possible, right? Because it compresses because the comes from the posterior pituitary.
Yeah.
Most of the hormones we think of come from the anterior pituitary, right? And so this would be compressing that posterior pituitary stalk. But of course, the hyponatremia is it sort of leads you potentially away from that.
Yeah.
But certainly a mass could cause diabetes.
Another thing Nick and I think we're thinking of when we were reading through this was like, is it somehow affecting just like the thirst regulation in the hypothalamus or something?
Right.
I mean, it's hard to say for sure, just kind of by looking at it. There's like a supracellular extension. My brain anatomy is like not great. So, I don't know exactly how that could involve like the hypothalamus and if that actually could have an effect on it. And I feel like probably clinically the best way to go about assessing that is to like just treat them as you would someone else with hyponatremia and see if it gets better or worse. But yeah, when Nick and I were trying to piece everything together, that was something that
Yeah, and those microadenomas, so ones that are like less than a centimeter, those tend to be the ones that are like functional or producing hormones. The macroadenomas are the bigger ones. They can be functional, but they tend to be like non-functional and have more of those like compressive mass
The
effect
mass
symptoms.
Right.
Yeah.
He wasn't having any eye stuff, was he?
Why?
Like visual?
Why do you ask?
Oh, because like bitemporal hemianopia.
Yeah, it's a good question.
We'll get back to the answer. I'll answer that.
I learned
did a
that.
very good thought. Yeah.
I will
We also
give
have
you
the same thought. So the next aliquot, we have all of the hormones over here. So we got a cortisol, which was normal 9.2, ACTH 39.9, also normal. Prolactin was 6, the normal being less than 440. FSH, LH, GH, all normal. Testosterone, also normal. And then the TSH, free T4, normal. And then they had ophthalmology see him, and they confirmed that there are, in fact, no visual field deficit. So what are you thinking based on all of this?
Well, it seems obviously at this point less likely that it's some sort of functional mass. But I think obviously if you do find it, even if it ends up being an incidental finding, you obviously need to work it up, and also that can give the patient some sense of mind or some peace of mind, because it's a really alarming thing to be told that you had a mass in your brain. But yeah, at this point with all of those within, that makes it less likely. And then also the fact, like Veena was talking about, that there are no visual field deficits, then at least it's not pressing kind of the optic structures in that area.
Yeah, I think that's a really good point. It's like you tell someone that you found something in their brain and they kind of like stop listening to everything you say after. It's very scary. Yeah. What you tell them after is like most likely going to be, this is something that's relatively common and benign, but regardless, something that like needs follow up. And so I think that's probably one of the harder parts of like hospital medicine is like you go and you work all this up and like you find all these pulmonary nodules or liver nodules. And like these are all things that like need to be followed up on an outpatient basis. And so being able to like communicate that to the patient, making sure that they're like getting the follow-up they need for it, even if it's not something that's like kind of acutely causing the symptoms that they're having now.
I think from here we can kind of, like Emma was saying, rule out any of like the functional tumors like we talked through earlier, and it doesn't seem like any of the hormonal imbalances, if they were present, would cause this picture of electrolyte imbalance anyway at this time. So I think we need to probably start treating the hyponatremia.
I agree.
Yeah.
That's a perfect segue. But well, I guess real quick before we segue, even though I said it was a perfect segue, Megan and I were also just kind of thinking about it because we talk about ADH so much as a hormone, and like we're looking at all these hormone levels, and like why wasn't ADH here? And like ADH isn't really like a lab value that we get. Like the molecule itself has a half-life 24 minutes, and it's not routinely measured. So we have to kind of take other information in order to determine the ADH status of the body. It can't be measured as like a lab.
And so something the nephrologists really like, because like I said, like you have SIADH, you want to, like the first thought would be like, okay, well, let's check the ADH level, but it's not something routinely done. So they use the serum uric acid as a good indicator of SIADH. And so like a lot of times if you have So like SIADH, you'd expect the urine to be really concentrated. And so you can either see that in like SIADH or someone that's just like really intravascularly depleted. But for the patients that are intravascularly depleted, you expect their serum uric acid to be high because they're in like a state of, low intravascular volume. The body's trying to reabsorb it. But for SIADH, for reasons I think that they don't fully know, the serum uric acid is actually pretty low. So that's a good test that they kind of order pretty routinely actually for hyponatremic patients where they're concerned about SIADH. And that kind of helps guide their management.
Walk us through what you think the final diagnosis is before we give you a little bit more.
I think we're gonna go with like too much free water consumption. Septogenic polydipsia.
Yeah, and I think that we kind of have walked through looking at a lot of the other causes. We talked about other electrolytes and talked about kidney causes, and we had this incidental finding that kind of threw us off track and rolling out, which was good and very helpful. But yeah, I think coming back to that initial thought, just based on the urine study, the sodium, and then also, this psychiatric history, definitely. And again, at least for me, the fact that he's kind of an otherwise healthy, younger guy, all kind of support, kind of put that diagnosis up for me.
I really like how you laid that out.
So just a little bit more information. The patient's legal guardian was contacted and provided further collateral history. The patient had been living with his aunt and cousin, recently stopped taking his psych medications and disappeared from the home. For collateral history, the patient had been drinking approximately 12 16-ounce water bottles per day, as well as a significant amount of soda and coffee. And so you guys got it. Primary polydipsia was the diagnosis. I think you guys win the award for clinching the diagnosis faster than him. But yeah, so like a really interesting case, I think. And yeah, I think there's like just a ton to learn from it.
I agree. I feel like the joke about internal medicine is that we all like love sodium.
Oh, guys, it's a slow one for that.
Yeah. And it's true. I mean, I think it's so much fun just thinking through. There's so many different things that it could be. And so you have to look at the urine and the serum osmolality and just so many different picture or pieces of like the history and lab studies that go into it. And so, yeah, we had a lot of fun going through all of it and presenting it to you. You guys did wonderful. So congratulations on getting it.
Thank you. I feel very accomplished.
Thank you for all these clinical pearls. And now we're going to know so much about sodium when we go to internal medicine.
Slow everyone away.
I forgot you guys have your flat iron.
We have it.
I promise. We'll rot them all to you. Yeah, just for our listeners' knowledge, our two discussants haven't even done their internal medicine clerkship yet. And their reasoning skills are
Yeah, you guys are just discount. I'm not going to check the box.
Put that in your patient. I think the only other thing I had thought about that I recently learned reviewing for this case is we think of hyponatremia and sodium, but it's really an osmolality issue more than it is an actual sodium as an ion electrolyte issue. Because sodium's our best marker surrogate for serum osmolality. So a true hyponatremia is because they're hypoosmolar, and talked about how that, cerebral edema ultimately leading to herniation as being the catastrophic consequence. So I think Megan, in this great case, you guys did amazing. Love to hear your reasoning. It's just so fun from our perspective just to sit back and listen. I think Megan and Nick did a great job hosting, and they're going to walk teaching points now.
Yeah, we got a couple quick teaching points. I feel like we covered a lot of it just talking through everything, but I did a lot of nephrology research while I was preparing this because no matter how many times you try to understand sodium, you still realize that the nephrologists are wizards and none of this makes any sense. But anyway, I did try to do a little bit of learning and just kind of understanding, because my thought was this does seem like primary polydipsia, but like maybe is there a little aspect of like a tea and toast something going on as well? And so I was reading a little bit just about kind of how that all works and why you see the hyponatremia with like the tea and toast diet and the beer potomania. And so basically for those patients, you're just consuming like beer or tea, which is carbohydrates. And so carbohydrates are just like metabolized to carbon dioxide and water. And so they were joking, they're like, for a nephrologist, a bowl of spaghetti is basically free water, because anytime you're just like metabolizing carbs, you're basically just giving your body free water. And so your kidneys are great as long as they're kind of normal, healthy functioning kidneys at regulating like your serum osmolality and kind of excreting your osmolar load for the day. And so usually it's like 10 milliosmoles per kilogram is what you can expect for like a normal kind of American diet. So for like a 60 kilogram person, you can expect them to take in like 600 milliosmoles a day. And then your kidneys can produce urine that's either really dilute or really concentrated, depending on like how much water you're drinking. But they can only kind of do that like within certain bounds. So they can produce urine as dilute as like 60 milliosmoles per kilogram or as concentrated as like 12. And so what that means is like there's kind of like a maximum amount of urine that you can kind of put out in a day. And so if you're taking in less solute, you're just not going to be able to put out as much urine despite how much fluid you're drinking. And so that's kind of where the issue comes with becoming hyponatremic, is that you need that solute load to be able to create urine. Otherwise, you just end up retaining all of this water. And so same thing kind of on the other end of the spectrum. You can only create urine that's like so concentrated. And then after that, you just end up becoming like hypernatremic. So that was something that I found really interesting, and just kind of being able to understand a little bit more about like why you see those electrolyte range.
And Megan, if you have renal insufficiency,
Yeah.
those
Yeah.
those boundaries or whatever start shrinking.
Yeah. And so that's for normal kidneys, but any like dialysis patients, end-stage renal patients, any water they're drinking is basically just diluting their serum osmolality. So something that you have to be really careful about.
The next thing we kind of just wanted to go over was primary polydipsia itself. And like, so just generally with this disorder, it's a disorder in which patients just have a primary increase in thirst, and it's usually associated with psychiatric illness or psychiatric conditions. So there was a study that was cited of 239 hospitalized patients with mental illness, and found that 6.6% of them had some history compatible with compulsive water drinking, and half those had intermittent symptoms of hyponatremia. The mechanism is not fully understood, but presumed to be a central defect in thirst regulation. And so what happens is essentially these people usually have normally functioning kidneys, but they drink so much water that it exceeds the capacity of even normally functioning kidneys to excrete the water. So we say that normal patients can excrete about 400 to 600 milliliters of urine an hour at their like maximum rate. So if you drink more water than that, then you're just not going to be able to excrete it at a fast enough rate. And so this is what's going to lead to essentially diluting your body volume and driving that sodium level down. When we think about patients who have psychiatric illness, there are a lot of complications related to ADH secretion and regulation that can complicate things. So for example, like there are many antipsychotics, I know Veena had mentioned like SSRIs can cause like SIADH, but also other antipsychotics can cause it, and patients who take that tend to be psychiatric. And then so for like a lower sodium concentration might be required to shut off ADH these patients. And then regarding treatment, so it can be tricky because, like, for example, this patient, we don't know exactly what it is causing. So you want to treat the sodium. But if you know the diagnosis is primary polydipsia, then really the treatment is just to restrict them from drinking water, which, when you have a sodium that's that low, generally when patients are symptomatic and their sodium is like less than 120, you want to give like hypertonic saline. But this is like one of the few exceptions to that because their kidneys are functioning normally. And if you overtreat, you can drive their sodium up too fast and cause some like pontine lesions.
I think there's a rule for when you bring the sodium down. Is there a rule for bringing the sodium up?
Mm-hmm. Yeah. So it depends on if they're asymptomatic or symptoms. So like for asymptomatic patients, I think you still don't want to go up by more than 12 a day that I was listening to. So it's like half a mil equivalent an hour. But I was listening to a nephrologist earlier who said he just like shoots for 6 a day, because if you overshoot, you're still like way like below the limit. And for those patients that are asymptomatic, like the way you're going to hurt them is by correcting it too fast. Like with their hyponatremia now, they're not maybe like a little dizzy if they get up, but otherwise they're like doing pretty well. So you could cause damage by correcting it too fast. But if you do it too slow, like they're just going to kind of stay where they are. So, and then the patients that are symptomatic, I think I was hearing you want to do like 5 in the first hour and maybe 10 going on like the rest of the day after that. But I would have to double check. But yeah, going either direction, either from like hypernatremia back to becoming like or isoosmotic, or hypo to iso, you want to be careful, because either way there can be pretty serious consequences with all the fluid shift.
So certainly the bottom line is these patients should be in the ice, because they need to be monitored really, really carefully, because it can harm them by correcting them too fast. And, again, you guys correct me. I always think of this term central pontine myelinosis. That's the term for the damage that you do if you correct them. I know I've seen at least one in my. There's things that's paralysis of upward gaze. They get gaze disturbances. You're on neurology. You should remember all that.
I think they get like the full logged in. Yeah, which is very scary.
There's that memory tool for correcting. It's like low to high, your pons will die.
Yeah.
High to low, your brains will blow. So meaning you get the central pontine myelinolysis when you overcorrect a low sodium, but you also want to be careful about overcorrecting high sodium to low, because then you can get screwed.
Another pearl I picked up kind of reviewing for this, nephrologists are tricky and they love their physiology. And I've seen this and never thought about it any further, but in patients with hyponatremia, especially when the etiology is not certain in the moment, and you're already treating it, this patient would have been treated while diagnosis is still on her way. They give DDAVP concomitantly with glutes. And just to hear that, it's kind of counterintuitive. But if you think about it, it's actually fascinating. And it basically ensures that your body's at the maximum amount of ADH. So you're making the solution a bit simpler. So you're not allowing your body to produce urine in that sense. And it just allows for tighter control. So they call it the DDAVP clamp or DDAVP lock. And it just ensures that you avoid overcorrecting too quickly when you don't entirely know what the cause is, because patients like this one with primary polydipsia or hyponatremia, you give them normal saline, their sodium can shoot up. They're the quickest to respond. So it's just a safety mechanism.
Yeah, especially with the hyponatremia and the tea and toast, they're just not used to having that high an osmolar load. So you give it to them and their kidneys just dump out a bunch of urine. So you can shoot their sodium up really quickly, which obviously can be really detrimental. So, and then just another kind of interesting pearl, just a lot of times these patients are walking in and you're not sure, is this polydipsia, is it SIADH? So if you give normal saline for SIADH patients, they have the ability to concentrate their urine to such high degrees that you're basically just giving them free water, and it can actually worsen the hyponatremia. So just being really careful with the fluids for these people. Sometimes I'll do really small kind of normal saline challenges just to see how they respond to it. But you wouldn't want to bowl as a patient with normal saline because you run the risk of worsening.
And also, if you look at if you look up online treatment algorithms of hyponatremia, one of the major branch points for a lot of them is it acute hyponatremia or is it chronic? And so sometimes it's hard to tell. So, but if you know that it's really acute, then theoretically you can correct it faster because your body hasn't learned how to live at a lower number. Versus if you're living at, let's say you're living in the 120s, your body's kind of adjusted its osmostat to that level because the brain kind of learns to just throw out osmoles out of its cells to prevent them from swelling. And so it can prevent the symptoms of cerebral edema and hyponatremia. So yeah, that's just kind of one of the things to also think about in terms of correcting. If it's chronic hyponatremia and symptomatic, it can be a little trickier.
They're really good.
Girl, she had always 129, and then she dropped down to 125, but she was also delirious from something else. So then teasing out whether it was due to the drop from a chronic hyponatremia versus other delirium.
Yeah, sure. Yeah, it's never easy. Yeah. Thank you guys so much. This is an awesome episode.
Hold on, I've got some stuff to say here. Because we haven't got to what I found to be the most interesting part of this case. And I'm telling you about the case now. And so the story with this guy is he was found downtown actually punching. And so that's punching the walls of some stores downtown. So he was actually brought here by and comes into the hospital and all this stuff, goes to the ICU, all this stuff. And they correct his soap. And I'm talking to him. By the way, when I get him, the neurosurgeons are still very concerned about this mass. I really feel that he needs to have this pituitary, he needs to have this abnormal removed because it's going to put even though his visual fields are at risk, it's going to, his visual fields are common. And I remember talking to this patient and was telling me about how he's the CEO of a company in New York and he takes the bus every day from Chicago to New York. So it was unclear to me if his mental status was really due to his.
Yeah.
Yeah.
And it got to me, the interesting question was, surgeons had consented him to remove his pituitary tumor. My question was whether he really could consent to the procedure, given that he had this, this whatever. And actually, I think, and you could answer me this question, Nick, and that is, what psychiatric diseases, if you look at the gamut of psychiatric diseases, which one is most commonly associated with primary polydipsia? Because there is an answer to that also. And it is schizophrenia is the one that is most often. Other ones do it, but schizophrenia is the common one to do that. And so can you consent a actively psychotic patient to a surgical procedure, which they were happy to do because they were about to take him. And I said, wait a minute, you guys can't do that.
Yeah.
And he needs to be treated first. And I actually had to say, I put a lot of pressure I did get the psychiatrist to say that, because I thought it was, I actually thought it was unethical to take him until you made an effort to at least treat his psychiatric disease. So I had to put my 2 cents in on that, because I also found that to be a really interesting part of this case. And we assumed that his mental status was due to his sodium. And I didn't see him when he came in, but I really couldn't be sure that was
Yeah.
That's actually interesting, because Megan and I were talking about how he was like punching out windows. And when we think about like an altered from sodium, you think of it more as like a comatose. Yeah, just like but this patient is that seems more
sodium picture. Yeah.
So that's also
he was really, to his credit and everything, he was good. He was on a fluid restriction. He had somebody sitting with him, but we always talked about, I want to go get some water. I want to go get some water. But he was not. He was actually really. I thought he was kind of a really sort of one, but he was. He'd stopped all of his medicines,
Yeah.
and that really was probably more the cause of his mental status changes. And we got hung up on his sodium, which we probably used to because it was chronic, right?
Living there for years.
Right. Okay, you guys can be finished now.
All right. Well, thank you for that. That was wonderful. And thank you guys for being on the episode. So nice to have you on here. And thank you to all of our listeners for listening. And we'll see you guys next time.
Thanks again for listening. Person, time, and place. See you next time.